Yeah, so work in cellular senescence has progressed from looking at individual cells in culture to looking in animals and human tissue explants. Now this work has gone to what we call preclinical studies, that is, studies in several animal species that are approved by regulatory agencies, as well as in human tissue explants and so forth. And clinical trials have begun. Several of them have been published already. Initially, the results, they're very small trials. There's a long way to go, but the initial results so far look positive. Doesn't mean they'll be positive the whole way through. There are many trials underway now that are what we call double-blind, placebo-controlled phase 2 trials. Most of them for very serious conditions for which there are no other good treatments for people at the moment, because we're worried about risk-benefit ratio. So far, we haven't seen what we call serious adverse events that are directly study agent related. And the trials have been allowed to continue to proceed, so they haven't been stopped for safety concerns at this point. The early trials are beginning to show what we call safety, tolerability, and target engagement. That is, we are actually able, most likely it seems, to reduce senescent cell burden in people. But what remains to be seen is whether these interventions will be what we call effective and efficacious. That means, do they reduce symptoms? Do they reduce disease burden? Is there long-term safety, and so forth in humans? Initial results are looking positive, but that said, most clinical trials fail somewhere along the way, and that's why I think it's a good thing that multiple clinical trials across multiple indications are currently underway. I think the public should expect that many of the trials will fail, and public and politicians should not be turned off if they do, because that's to be expected. And that's why I think it's very important that multiple trials proceed in parallel rather than doing these trials in series. I also think it's important that physicians not prescribe these agents yet, except under some very limited circumstances where there's what we call emergency use. And I don't think patients should, or people, the general public, should be buying these agents from places like Amazon and taking them over the counter, because we just don't know what all the downsides are yet. So I hope that these agents will work. I don't know that they will. And we need to see, and we'll have to start with serious disorders with these agents being given one at a time at first. Then we'll look at combinations with other kinds of gerotherapeutics and things like lifestyle interventions, getting adequate sleep, exercise, and so forth. And another phase for disease-specific indications will be combining senolytics, drugs that selectively kill senescent cells, with disease-specific drugs that we already have, to ask if effects are less than additive, or more than additive. Early indications from preclinical studies indicate that these agents may be synergistic with disease-specific agents, that is, more than additive, but we don't know until we do clinical trials. So those will be the next steps. I think it's going to take 5 to 10 years before we have solid answers in people with serious illnesses, and before we can start thinking of secondary prevention trials where we have people with a moderate illness and are trying to prevent progression or development of another illness. And it'll certainly be a very long time before we can start recommending senolytics to completely healthy individuals who are not at severe risk from genetic or other kinds of markers of getting a serious senescence-related disorder. So for the general public, I think it'll be a while before we really know.